We have heard it again and again. You had anal cancer treatment, but were not prepared for the serious, oftentimes painful side effects. In response, ACF developed a comprehensive, evidence-based guide to help your body and mind recover following treatment. It's called Reset, and each letter corresponds with a specific action you can take on the road to recovery. Our goal is to make Reset a standard part of your meetings with your oncology team. Reset stands for relief for pain, exercise, pelvic floor, support from peers and professionals, eat to heal, and therapy for sexual health. We will have 2 Reset recovery focus sessions today. Dr. Emma Holliday will be our first speaker. Dr. Holliday is an associate professor of gastrointestinal radiation oncology at MD Anderson Cancer Center. Using the ACF Reset model, Dr. Holliday will address the short and long-term side effects of treatment and provide specific tips to address them. After her presentation, we will have a live Ask the Expert session with Dr. Holliday. The second Reset speaker will be Dr. Michael Lasala, and he will provide a deeper dive into something we've heard from you that you want to hear about: coping emotionally after cancer. We will have a live Ask the Expert session with Dr. Lasala as well. Now, please join me in welcoming Dr. Holliday.
My name is Emma Holliday, and I'm a radiation oncologist specializing in the treatment of GI cancers at MD Anderson Cancer Center. I'm thrilled to be speaking with y'all today about using the RESET acronym to mitigate the side effects of radiation therapy for anal cancer. If you're not familiar with the RESET acronym, I'll review it for you briefly. The R stands for relieving pain. The E stands for exercise the pelvic floor. S stands for support from peers and professionals. E stands for eating to heal. And T stands for therapy for sexual health. Over the next 9 minutes or so, I'm going to use this acronym and show you ways you can partner with your doctor to help mitigate common side effects of pelvic radiation for anal cancer. We'll start with the side effect many of my patients are most nervous about, and that's pain. Pain can happen during and immediately after pelvic radiation for anal cancer as a result of mucositis and/or dermatitis. Radiation can cause an internal burn called mucositis, which happens when the lining of the anal canal and rectum become raw and blistered. Some patients describe it as a constant dull ache that can escalate into a very sharp and more severe pain when bowel movements pass through the affected area. Radiation can also cause an external burn called dermatitis, which happens when the sensitive skin around the anus, in the groins, or other places in the pelvis becomes sore and blistered. I used to call this a radiation sunburn, but my patients who've been through it told me they don't like this term because they think it minimizes the degree of discomfort that it can cause. For some patients, pain can persist months or years after the radiation has ended. Chronic pain, when it happens, can be caused by things like anal fissures, ulcers, hemorrhoids, or anal stenosis. So what can we do about pain? Pain relief is key, whether it's during the acute phase of radiation treatments or chronic pain that happens months or years down the road. Usually we need to take a multi-step approach to pain relief. We start with things that are simple, like regular sitz baths, perineal cool packs that can help soothe inflamed skin. Then we can layer in things like topical creams and ointments, petroleum jelly-based, lanolin-based, or prescription silver sulfadiazine can all help. Compound creams that include topical lidocaine can also help. However, most of my patients reach a point during treatment where they need oral pain medicine. The topical stuff just isn't cutting it anymore. I usually prescribe opiates once the pain is above what is tolerable for each individual patient. There's not a one-size-fits-all rule. Other types of prescription meds can help opiate pain medicines work better. Depending on a particular patient's needs, I will sometimes add an NSAID, a nerve pain medication like gabapentin, or a muscle relaxer like cyclobenzaprine. For chronic pain related to the aftermath of treatment, some patients need to be on prescription medications for months or years. I work with patients at each of their follow-up visits to try and streamline their medicine, de-escalate, and minimize the side effects of medicines taken for side effects of radiation treatment. In addition to anal pain, patients can also have long-term muscle, joint, and bone pain after radiation for anal cancer. This can come from scar tissue and fibrosis that can limit range of motion and lead to pain in the low back and hip flexors. Some patients also develop bone pain from insufficiency fractures or breaks in the tailbone, low back, or hips. So what can we do about that? Prevention is key for bone, joint, and muscle health after pelvic radiation. For bone health, taking enough calcium and vitamin D is key. There are online calculators that can help you determine the correct dose for you. Regular weight-bearing exercise can also strengthen your bones, and daily stretching, particularly stretches for the hip flexors and low back, can help maintain range of motion and reduce stiffness and discomfort. I also recommend regular screening DEXA scans for bone density. This allows us to identify and start treating conditions like osteopenia and osteoporosis that are more likely to happen after radiation to the pelvis. For patients who do develop radiation-induced bone fractures, most will heal on their own, but rarely patients will need to be referred to experts to discuss potential interventions or procedures to fix or strengthen bones. During radiation, patients can have irritation of the bowels called proctitis or colitis. Patients can experience rectal or bowel spasms that feel like cramps or gas pains. Patients can also experience frequent bowel movements or diarrhea, and bowel movements can become more urgent, which means they may not have as much notice from the time you feel like you have to go to the time when the bowel movement is actually happening. Some patients will even lose control of their bowel movements at times. Long-term, radiation scar tissue has the potential to change the way the bowels work. Many patients will describe their new normal as being more prone to diarrhea, having unpredictable clustered bowel movements, sometimes after eating, and having more urgent bowel movements. Again, some patients even lose control of their bowel movements at times. So what can we do about this? While different anti-diarrheal medicines can help a lot during the acute on-treatment phase of radiation to the pelvis, pelvic floor physical therapy can be a game changer for patients having bowel dysfunction after treatment. Pelvic floor physical therapy can help to strengthen and recruit muscles in the pelvic floor, and this can actually help improve both bowel and bladder continence for patients who are having trouble controlling their bowels or their bladder. Let's shift gears now and talk about the emotional problems pelvic radiation for anal cancer can cause. We know depression and anxiety are both very common among patients diagnosed with cancer. We also know that most people are not getting the help they need. Reasons for this include people normalizing distress around cancer and doctors not having enough time to assess and address these symptoms. So what can we do about it? First, I think all of us need to be better about acknowledging feelings of anxiety and depression triggered by cancer and cancer treatment. I personally try to bring it up with each of my patients towards the end of radiation because for many, depression and anxiety can show up just as this active phase of cancer treatment is ending and you're just sitting around waiting for the first follow-up scan to see whether or not the treatment has worked. Other tools in the toolbox include peer support, either in groups or one-on-one buddy type systems. Some patients benefit greatly from referral to an oncopsychiatrist who has special training and expertise in treating patients with cancer. Talk therapy can be a very valuable tool, as can medications. Pivoting back a bit to bowel problems, I want to focus next on the vital role that diet and nutrition can play in recovery. from both the acute side effects as well as the chronic long-term problems that can happen down the road. During treatment, my patients meet with a specialty trained dietitian every week. They go over personalized hydration, calorie, protein needs, because we know staying well hydrated can be a challenge during radiation and chemo, but it's really important to feeling your best. Many patients also notice that easy to digest foods like simple carbs on the brat diet can help treat symptoms like cramping, bloating, and diarrhea. But each patient is different, and that's why checking in regularly with an expert can be very valuable. With regard to chronic bowel changes after pelvic radiation, our dietitian colleagues can also provide invaluable input here. Many patients find that certain foods or eating at certain times of the day can be triggers for GI upset. Keeping a food diary can be very valuable to identifying and avoiding personal triggers. Other simple interventions, like taking concentrated psyllium fiber or magnesium supplements at night, can help with people who have morning clustering and urgency, because they can help those bowel movements stick together and pass more completely in the first morning bowel movement. Last but certainly not least, I want to touch on sexual problems that can happen after pelvic radiation that can benefit greatly from sexual health therapy. Radiation can cause changes to the vagina that cause it to be shorter and more narrow and more dry than before treatment. All of these can contribute to painful or difficult sexual intercourse. Radiation can also cause changes to the blood vessels and nerves to the penis, as well as the prostate gland and seminal vesicles. These changes can lead to problems with erection and ejaculation. Finally, pelvic radiation has the potential to induce hormone changes for both men and women. Radiation can cause early menopause for women, low testosterone for men, and infertility for both men and women. So what can we do about it? For women, using a vaginal dilator at least 3 times per week can decrease the scar tissue that forms in the vagina and causes problems. Pelvic floor physical therapy, again, can be really helpful for women having pain with intercourse post-treatment. Once patients start to notice the signs and symptoms of sexual problems after treatment, medications such as vaginal or oral estrogen can be helpful for some women. And men who notice sexual dysfunction can try prescription medicines or testosterone supplementation if there are no contraindications. Sex therapy is another great tool for both men and women adjusting to their new normal post-treatment. I'd like to end my talk by emphasizing the importance of having an open line of communication with your doctor and treatment team. Certainly, your doctors will have their own list of questions they'll ask you at each visit to get a sense of how you're doing, how things are going. But I wanted to leave you guys with a list of questions you can ask your doctor at each visit to make sure the conversations about side effect management are as productive as they can be. Number 1, how are my symptoms compared to with what you would expect at this point in treatment? Number 2, what options do I have for pain or symptom control? Are my side effects and symptoms as optimized as they can be? Number 3, what should I be on the lookout for in the next week, month, year? Do you expect things to keep getting worse? Do you think I'm about to turn the corner? Or have I reached my new normal and I need to work on getting used to being okay with where I am now? Number 4, what should I do or who should I call if things get worse? If my pain gets worse, if my bowel symptoms get worse, if I have more incontinence, what's the plan to deal with things if they get worse? And finally, who else can I speak to specifically about XYZ, be it incontinence, be it sexual problems, be it nutrition advice? Never be ashamed or reluctant to ask your doctor to bring other experts into the conversation, because we know it takes a village and it takes a whole family and a whole group of dedicated doctors and healthcare professionals to help get patients through the aftermath of pelvic radiation. With that, I'll leave you. Thank you for your time and attention. I look forward to the discussion during the Q&A. Thank you so much.